The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast. After learning about intraoperative cholangiography, bile duct exploration, and the assessment and treatment of bile duct injuries in part 2 of this episode, we now move on to part 3, focused on post-cholecystectomy bile leaks and the assessment and treatment of choledocholithiasis and acute cholangitis.
One thing that I would like to mention is, as we previously discussed, that sometimes on imaging you find a biloma that could be from a small duct leak, and likely that is going to be from a cystic duct leak. So how would that management be different from what you previously described about bile duct injuries from a common bile duct?
Yeah, so I think everything that we talked about earlier referred more to an injury to the common bile duct or the common hepatic duct. But I think the reality is that a lot of the fluid collections that we suspect bile duct injuries from are like bilomas in the gallbladder fossa, and they can come from, I think one of 3 areas, right? So they can come from the gallbladder fossa itself, which could be like ducts of Luschka. They can come from the cystic duct stump because, they're controlled with clips, and sometimes the clips are not all the way across, or it's cut close to the clips. They can fall off, and you can have a leak. They are presenting as a biloma. And of course, the third location is the injury to the common bile duct or the common hepatic duct, which we've already talked about. So I think that if there is a biloma, usually the treatment is first thing is they get a drain to drain that, and then either an MRCP or an ERCP. And if that shows a leak coming from the cystic duct or the gallbladder fossa or the duct of Luschka, or even sometimes a pinpoint leak from the side of the common bile duct or the common hepatic duct, which could be a thermal injury, then these can be managed just by a sphincterotomy through ERCP and a placement of a stent. What that allows is preferential drainage of bile into the duodenum, because now you have an opening, decreases the pressure of bile in the intrahepatic bile ducts, and that can also exclude the cystic duct and stop the leak there. And usually those are very successful in managing these milder complications. Now, of course, that's why we have a whole grading system, which is very important, because they delineate the anatomy and also give a good representation of the location of the injury. So there are several grades, and I think that they might be in the chapter, but I think that you have information on them, so I'll let you go over the different grades of bile duct injury.
So there is a detailed classification of the bile duct injuries listed in the book, but briefly going over the Bismuth-Strasberg classification of bile duct injuries can be divided into 5 categories, depending on the location of injury. So grade A is a leak from cystic duct stump or duct of Luschka. Grade B is occlusion of aberrant right hepatic duct. Grade C is transection without ligation of aberrant right hepatic duct. Grade D is lateral injury to a major bile duct. And then grade E covers injuries to common hepatic duct and can be further divided into E1 to E5, depending on the location of the injury in relation to common hepatic duct bifurcation. So, Dr. Khan, switching gears now and discussing the presentation and management of choledocholithiasis and acute cholangitis. Can you quickly talk about how a patient will present with choledocholithiasis compared to how we previously discussed the presentation of symptomatic choledocholithiasis or acute cholecystitis?
Great. So choledocholithiasis, in other words, is just a stone in the common bile duct. So we talked about stones in the gallbladder causing biliary colic and cholecystitis. But sometimes what can happen is these stones, especially if they're small, can slip out of the gallbladder through the cystic duct and find their way in the common bile duct. And, at the end of the common bile duct, as you recall from anatomy, there is a pretty tight muscular sphincter, and some of these smaller stones cannot duct pass through there, and they can cause biliary obstruction or symptoms that are referred to under the spectrum of choledocholithiasis. They can also irritate the pancreas, which causes pancreatitis, and sometimes if the bile that's blocked gets infected, then you get choledocholithiasis with infection, which is cholangitis, and that can be a pretty life-threatening problem. It's also important to know that while most of the incidents of choledocholithiasis are from stones that arise in the gallbladder, you can have primary choledocholithiasis too, and that's often that there's either a stricture or something that acts as a nidus for stone formation in the main bile duct itself. So the source is not the gallbladder, which would be secondary choledocholithiasis, but rather the source is primarily in the bile duct.
So moving on to the lab workup and imaging studies, how would those be different?
Yeah, so I think that for anybody that you're suspecting a biliary problem, right? So cholelithiasis, cholecystitis, biliary colic, or choledocholithiasis is important to try to figure out what the problem is. So clues on a physical examination, again, fevers would be suggestive more of cholecystitis or cholangitis. But I think liver tests, are important in sometimes guiding us between the two. So if you have somebody with a high-grade bile duct obstruction or choledocholithiasis, then often the liver tests are significantly abnormal, especially the bilirubin and the alkaline phosphatase. You can have AST and ALT elevation as well, which can be pretty sensitive for choledocholithiasis. In patients with cholecystitis, you do have some abnormality, but typically it's not very high. If you have somebody's bilirubin in the 5, 6, 7 range, usually it's suggestive more of a bile duct obstruction. Imaging studies, again, if you have a dilated bile duct on an ultrasound, so it's something that's more than 5 millimeters in a younger patient or more than a centimeter in an older patient, and intrahepatic and extrahepatic biliary dilation, then that's suggestive of it. Often on ultrasound, you can see sometimes an impacted stone, and that is another clue. Or seeing small stones in the gallbladder is another clue, because that could be the source of the stones. I think it's usually the gallbladder can be distended because the bile is backing up into the gallbladder too. So it's important not to confuse that with cholecystitis just because the gallbladder looks big. It's important to look at the wall of the gallbladder and also any fluid around it, which would suggest cholecystitis. But usually in choledocholithiasis, those signs of cholecystitis are absent.
With the management, I know we have basically touched on all the modalities that we can offer the patient. We can do an ERCP, we can offer cholecystectomy, we can do an intraoperative cholangiogram. But regarding the timing of those modalities, how would they be different for the management?
Yeah, so I think that if somebody comes in and the primary problem is an obstructed bile duct, and we're suspecting stones, then I think that the first priority is to open up the bile duct. In this day and time, most of these patients will get an ERCP, and in the modern era, the GI doctors are very successful in taking care of the problem, doing a sphincterotomy, placing a stent, and removing the stones. So that's part one of the problem, right? Clearing out the acute presentation of obstructive jaundice. But the second part of the problem is that we still have the factory for the stones, which is in most cases the gallbladder. So the recommendations are that for patients presenting with bile duct obstruction from gallstones, once the bile duct has been cleared, the next step would be a cholecystectomy, ideally within the first 2 to 3 days of the ERCP. And the reason for that is that there is a risk of the stones passing again, and the patient's running into problems from either obstructed bile duct or pancreatitis if too much time is spent after the patient's initial presentation. And if sometimes you have a patient where you have an obstructed stone, and the patients, and you know that beforehand, but you don't have ERCP available. And sometimes that happens in smaller hospitals. So I think the options there are either to transfer the patient to a tertiary level care where they can get that procedure followed by the cholecystectomy, or consider going to the OR and doing a bile duct exploration with removal of stones through some of the ways that we talked about earlier, and doing a cholecystectomy at the same time. But that, of course, is determined by the expertise of the surgeon as well as the facilities available at the hospital where they're at.
So just to add one thing regarding the diagnosis of acute cholangitis, Dr. Khan, if you could briefly talk about, this is more relevant also to the medical students, and it's a very commonly asked question as to what are the signs and symptoms the patient presents with who have an acute cholangitis.
So it's very important to recognize acute cholangitis, and it's because the management is very different compared to, it's more of a life-threatening emergency, and it can cause problems. So what is cholangitis? So cholangitis means that there's an obstruction of the bile duct with either a stone or something else, as opposed to simple choledocholithiasis where there's just an obstruction but no infection. In cholangitis, the bile gets super infected by some of the biliary tree pathogens, and you get a lot of infection in the obstructed bile. So essentially you have pus under pressure, and that can cause severe sepsis and multi-organ system failure if left untreated. So the patients who present this will have many of the symptoms of cholecystitis or biliary colic. So they'll have often right upper quadrant pain. They'll have fevers, and if those two are present in combination with jaundice. So this is a triad that if present, you absolutely have to think about cholangitis and go into emergency mode. These patients should be made NPO, start broad spectrum in antibiotics, often with gram-negative and anaerobic coverage, and start on IV fluids. Most of the time you need to get an urgent consult into GI for an ERCP, and these patients typically go and get an ERCP within the first 24 hours or 12 hours of presentation. And the improvement in symptoms is remarkable. With an ERCP, they do a sphincterotomy, and all of a sudden you see a lot of pus and stones and debris, and the patient feels immediately better. Usually the recommendations are that once the bile duct has been decompressed and the infections taken care of, is that they go to the operating room, again, within the first 24, 48, 72 hours to get a cholecystectomy, ideally during the same hospital stay, because there is a significant risk of recurrent cholangitis and passing of stones that's directly proportional to the time that is spent between the first presentation and the time taken to do an operation.
As Dr. Khan mentioned, the signs and symptoms to look out for in a patient who comes in with acute cholangitis are fever, jaundice, and right upper quadrant pain. And these three form a triad called a Charcot's triad. In some patients, the other signs to look out for will also be hypotension, which will highlight the hemodynamic instability, and altered mental status. So when all these 5 signs are taken together, it's called a Reynolds pentad, and that can be helpful in identifying the patients with acute cholangitis early in an emergent setting. Dr. Khan, that was a ton of great information that we went through about benign biliary diseases in such a short time. Thank you so much for being here with us today. As always, if you would like to learn more, you can check out some of the literature we referenced in today's episode, which you can find in the show notes. And a full review of our discussion can be found in the Washington Manual Surgery, Chapter 18. Thank you.
Thank you, Usman. It's always a pleasure.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams and Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.